Good afternoon, everyone. Thank you all for joining us. And again, I just want to say a special welcome to all the folks who are from other villages who decided to come on. I'm happy to introduce Dr. Stephanie Trifoglio. I'm on the board of the village in Hyattsville, Maryland, Hyattsville Aging in Place. And I first got to know Dr. T through that village because she's been working with us out here for a number of years doing various kinds of educational presentations for our members that have a medical orientation. And I also will just note that she's my personal doctor and an amazing doctor at that. Dr. T is both licensed as an internist as well as in gerontology. She's a geriatrician. And I am going to leave it at that and let Dr. T take over. And if you want to say more about yourself, Dr. Trifoglio, if not, just go ahead and start your presentation.
Well, thank you very much, and thank you for having me. I am an internist and a geriatrician, and we can just go ahead and start the first slide. Jonah, do you have the presentation? Thank you, Jonas. So our topic this morning is dementia, and it's a tough topic, so thank you for bearing with me, and we're going to do some hard work this morning. Dementia is pretty tricky because we talk about it a lot, but a lot of people don't really know what exactly it is. So this morning we're going to talk about how to define dementia. We're going to focus on the primary dementias. We're going to spend a few minutes talking about what's normal and what's not in terms of our mental status and abilities. And then we're going to spend a little time talking about preventing dementia. Most of you are here this morning, I guess, because you're worried about developing it. So we'll take a few minutes to talk about how to prevent it. Okay, so first slide. Okay, so dementia, we're going to talk about some basic things here, and we're going to talk about vocabulary for a little while. And bear with me, because if you have the vocabulary, everything else becomes more clear as we move along. So I'm going to ask you to be a little patient and just work with me for a few minutes, and you'll find that it gets easier as we go along. So dementia is an acquired syndrome reflecting a decline in memory and cognition that affects daily life in an alert patient. And we're going to take this one step at a time. It's acquired. So we're just going to pause here for a minute. Acquired means you develop a normal intellect, and then you become more confused, loss of memory, loss of cognition with a problem with your daily life. That is, we're not talking about our Down syndrome patients, people who had congenital cognitive impairment. This is somebody who achieved normal intellect and a normal function, and then they started to decline. So it is an acquired syndrome. It reflects a decline in memory, and usually with dementia, it's short-term memory first, and then long-term memory. Our dementia patients usually have trouble with forgetting what happened this morning. What did I have for breakfast? Did I eat breakfast? What happened yesterday? But they remember long-term. They don't remember that they saw Susie this morning, but they can remember they went to high school with Susie, and oh, wasn't that funny when they brought the frogs into the English class? And oh, didn't they get into trouble? So it's a decline in memory, usually short-term first, and then long-term. And it's a decline in cognition. And we're going to talk about cognition in a minute. And it affects daily life in an alert patient. That is, we're not talking about comatose patients. We're not talking about patients on a ventilator. We're not talking about patients who are so far declined that they can't respond. These are alert patients who are functioning. And it affects daily life. And medicine has a way of defining daily life and how it is affected. And we're going to talk about that also. Okay, next slide. So what is cognition? And cognition is really how we think. It's how we know things, how we reason things out, how we perceive and sense and recognize and judge and conceive of things. So patients who have cognitive impairment, they stop knowing things. They forget facts. They forget knowing that how to go places and how to function. They can't reason things out. If I go outside without a coat and it's 12 degrees, I'm going to be cold. They can't perceive and sense. I'm shouting at you. They don't sense that that's upsetting you. They can't perceive that they're making you upset, and they can't sense your reaction. They have trouble with empathy and ultimately loss of empathy. They stop recognizing. They don't recognize acquaintances, and then they don't recognize the family. Judgment is a big problem. Somebody stops them on the street and says, I need money for a cup of coffee. Would you give me $3,000 from your ATM? They can't judge that maybe that's not a reasonable thing to do. There's a little fire in the trash can. What should be done? They can't judge that maybe they should be putting that out. They have trouble with judgment. What is a reasonable course of action? And they can't conceive of the bigger world. Everything becomes more concrete. Oh, those fires in Los Angeles are quite beautiful. They can't conceive that maybe the people there can't breathe or their homes are at risk. They cannot conceive of the bigger world. Cognition is how we think. It's our intellect. Cognitive impairment is a big component of dementia. So memory is part of it. Cognition is a big component. Next slide. Cognition is also any process whereby one acquires knowledge. It's learning something new. People who have dementia, they can't learn something new. You get a new microwave and the power button is on the right instead of on the left, they can no longer use that microwave. It's learning something new, even simple things. So I want to take an aside. All of you who are Zooming with me today, you must not have dementia because you learned how to Zoom. So I'm proud of all of you. Learning something new is a real marker of the ability to function with cognitive competence. Cognition, the ability to learn something new. Okay, next slide. Well, now we're in trouble. Perfect. Okay, so we talked about impairment of daily living. So in medicine, we often function as a team. I'm a doctor, but I work with my nurses and my physical therapists, my occupational therapists, and my geriatric care managers. And we often will talk about impairment of activities of daily living. They help to define how much help does a person with dementia need. And we talk about these activities of daily living because when you start to be impaired, we really get how much help a person needs and how far down the spectrum of dementia they are. And the basic activities of daily living require us to take care of ourselves. So this morning I got up and I took a shower. I put on my clothes. I brushed my hair. I did go to the bathroom. I had some breakfast. And before any of this, I got out of bed, sat in a chair. These are the fundamental and basic activities of daily living. I'm assuming most of you did all of these things all by yourselves. These are the things that make us independent in our fundamental and basic activities of daily living. When you can do all of these things, you are independent in the very basic functions of daily life: bathing, dressing, grooming, toileting, feeding, transferring from bed to chair. In the advanced stages of dementia, all of these activities are impaired and need to be assisted. Next slide. But before we get to the basic activities of daily living, we lose instrumental activities of daily living. Telephoning. It could be a landline, which is simple to use, or using a cell phone. But even communicating via one of these medical alerts. We have patients who have a medical alert and they don't know to push the button when they're on the floor, and they will lie there for 2 days because they can't push the button to call for help. So an instrumental activity of daily living is to be able to call for help using some instrument. Prepping meals. The early sign is leaving the stove on and the food is burning. But sometimes they are unable even to put a simple meal in the microwave and take it out. Putting it on for 10 minutes when it should be 1 minute and the food is burning. not using the microwave at all, leaving food out so that it spoils. Prepping meals is an instrumental activity of daily living. Managing finance. So this means being able to make change in the market and getting accurate, giving a $20 bill for $1 and making sure you're not being taken for a ride, but also making sure that your household finances are paid. Are you paying for your electric? Are you paying for your heat so that these things don't get turned off? My office manager, Marjorie, she is half social worker, and she's lived in this area a long time. She very kindly always checks for the auctions of the houses in the area. And 3 times she has found our patients where their house is up for auction for failure to pay taxes. They've paid off their mortgage and they get confused. They forgot they had to pay the property taxes. She's called the families, they've paid them off and saved the house from going to auction for a $2,000 tax payment or a $600 tax payment. So managing finance, that's an instrumental activity of daily living, but people start to slip and it becomes a big problem. Taking medications is a very important problem. I'm an internist. I take care of patients with complicated medical problems, diabetes, high blood pressure, heart disease, and yet they may also be developing dementia. They may be cognitively impaired. Forgetting meds is a big problem, but taking too many meds is also a problem. I had one lady put them all in a bowl as if they were M&Ms. She took a handful every day. She got into trouble medically. Doing laundry. Patients come in and they're wearing yesterday's eggs or they're wearing, meatloaf from a week ago. We look at this as a clue to the fact that they are no longer able to do self-care. Doing housework. Are they living in a clean environment? Sometimes I need help from a social worker or the physical therapist will call and say, this patient needs additional help at home with all of these instrumental activities of daily living. Shopping, and right now with coronavirus, being able to shop safely, that's a major problem, and we need to make sure our patients are able to navigate that. And transportation. Driving is the granddaddy of all instrumental activities of daily living, because first you start to see fender benders, but we can see serious problems. The ability to drive a car and to be able to navigate the warning signs and the stop signs and the red lights and the people who are cutting you off, that becomes a big problem. But also reaction times and the ability to handle the unexpected. In another state, there was a problem with someone who was more confused and she didn't understand the moving stop sign. That moving stop sign was a 5th grader who had a stop up for the crossing guard, and there were little children crossing. And that person was so confused, did not understand, and she plowed over and hit the little children. So transportation is a big problem, but driving is a major instrumental activity of daily living. And then if they stop driving, can they get on the bus? Even the Greenbelt connection, can they navigate safely and go where they need to go? So these are the instrumental activities of daily living. And when you are cognitively impaired, these are the first things that start to go. And this is a way that we can start to see how the brain is no longer functioning, our intellect is not working, and we are starting to have problems. Okay, next slide. So I'm back to the slide that defines dementia. But now when you look at it, I hope you feel, oh, I understand this. Dementia is an acquired syndrome. It's a new syndrome in somebody who was developmentally normal mentally, but now they're having problems. It's a decline in memory, usually recent memory first and then remote. It's a decline in cognition, so their intellect is impaired, their reasoning, their judgment, their ability to function with their processes, their intellectual and executive functions are impaired, and it affects daily life in an alert patient. So does this make sense now? I hope it's a little bit more clear. That's what dementia is. Okay, next slide. But what is dementia in terms of all these names you hear about it? So there are lots of different kinds of dementias, and someone suggested the analogy that dementia is sort of like the United States of America. It's the big name, and then you have individual little states. So if dementia is the United States, we have, say, New England, which is the primary dementias, and then these sub little states. And then there are secondary dementias. I'm going to mention them briefly now, but we're not going to focus on them. And that might be the Great Southwest. So secondary dementias, they might be things like having a brain tumor might cause cognitive impairment, or having too much pressure in the brain from too much fluid, normal pressure hydrocephalus, that would be a secondary. Advanced Parkinson's disease, that might be a secondary. So that might be Wisconsin, or it might be another kind of state. So we have secondary dementias where you have a problem in the brain that is affecting you and causing cognitive impairment, memory loss, and that is a secondary category. And those are treated by treating the primary cause. If you have cancer in the brain, you treat the cancer. You don't necessarily try to focus on the dementia, you're treating the cause of it. But primary dementias is where we're going to focus today. These are dementias that are just the primary issue. And we're going to talk about the 4 major dementias, and I'm just going to briefly mention benign memory loss, which is not a true dementia, but you'll see it has relevance to our talk today. Benign memory loss is where you're losing memory more than just little forgetfulness, but it's not a true dementia because it's not associated with cognitive impairment. So we all have trouble with occasionally forgetting names, or forgetting where we left our keys, or misplacing our cell phone. But benign memory loss is forgetting appointments and more significant memory. And family and friends are noticing this memory loss, but it has not progressed to cognitive impairment. So this is sort of a gray area. And it's significant because 15% progress to Alzheimer's disease. We don't know when it presents who's going to progress, but it may be a warning, and that's why I'm mentioning it here. Many people as they age develop benign memory loss, and it just stays there. They just have more benign memory loss, and certainly at age 80 to 90, it's very common. But in the 60 to 70 age group, we do see it, and we don't know who's going to progress and who's just having benign memory loss, but it is not a true dementia. The most common type of dementia is Alzheimer's dementia. And this is the one that everybody is afraid of, I think, because we don't really have good treatment for it. This one is common in age 60 to 70, but you can get it at age 80, 85. There is an inherited component, but it can also arise with no inherited pattern at all. So it's not as though if you don't have it in the family, you're not going to get it. But also if you have it in the family, you're not doomed to get it either. So we don't have a good predictive model for you. And we can't say for sure who's going to get it and who's not. And the risk factors have not been elucidated. This is still a very difficult disease for us to be able to say who will have it and who won't. It usually presents initially with benign memory loss, and then the memory loss progresses to early cognitive impairment, and then more significant cognitive impairment, and then impairment in your activities of daily living, instrumental activities of daily living, and then your basic activities of daily living. And then ultimately in your advanced stages, people are at the very end, they are basically in the fetal position requiring total care with being changed, incontinent, and needing to be fed. It is a slow, steady, progressive decline, and it is a pretty smooth progression. Although the length and depth of the decline is variable. I have seen it take 10 to 15 years. I have seen it take 2 years. And so that variable decline changes, but it is a pretty smooth progression. What we find with Alzheimer's is that there are very few motor symptoms. Most people can continue to walk, and they continue to talk, and they continue to have full use of their bodies while their brain continues to decline. It actually makes it problematic to take care of them because they can wander, and wandering is a big problem with Alzheimer's disease. And they don't know where they are, they get confused, and then they can open doors, they can go out in the street. And so wandering is one of the hallmark signs of moderate to advanced Alzheimer's. So Alzheimer's comes with benign memory loss, and then it progresses through more and more and more cognitive impairment, worsening activities of daily living dependent on care. Vascular dementia is also known as multi-infarct dementia. And vascular dementia is because of atherosclerosis or hardening of the arteries in the brain. And this comes as a result of high blood pressure, diabetes, atrial fibrillation, and high cholesterol. What we see with this is often the result of a lot of tiny little strokes, and in all cognitive function. Like you might be able to do Sudoku, but you can't do a crossword puzzle. Whereas Alzheimer's is sort of slow and progressive, vascular dementia is more like discrete. You lose different kinds of things because it's different little strokes in different parts. As it becomes more and more progressive, the end result is very similar. So advanced multi-infarct dementia and Alzheimer's look very much the same, but the way and the path of getting there might be very different. And multi-infarct dementia can stabilize or actually improve. So if you've had a stroke, you've lost some word finding, you've had maybe, and you might have some motor changes. So you might be paralyzed on one side, or you might just have weakness in one hand. And then you might plateau for quite a while. I've seen people plateau for a year where they are in the moderate phase. They need help with maybe with some meal prep. They need help with doing their laundry, but they're still able to live independently if somebody comes in every day and double checks their meds, makes sure that they're clean, provides their meals, but they're able to still use the microwave, and they're still able to get in and out of bed alone, and they're still able to do their basic activities of daily living, but maybe need help with a shower twice a week. And they can stay that way sometimes for 4 or 5 years. Whereas with Alzheimer's, you're seeing that steady progression. So vascular dementia and multi-infarct dementia, that's usually the same. That is an interesting way of presenting, and it is a little bit different. Now, Lewy body dementia is not as common, and it is similar to Alzheimer's, except that you have more ataxia. That is, that the way that you move is different, and people tend to have more difficulty walking, and they have terrible hallucinations. It disrupts your sleep pattern. You're more awake at night, and you tend to have these terrible hallucinations. And if you use any of the medicines that we use for people with Alzheimer's that sometimes help them calm down, they have a violent reaction to the medications. So you actually get these in the brain at autopsy. You can actually see Lewy bodies in the brain, but clinically we know it because of the ataxia and the hallucinations. So it's not as common, and it tends to occur earlier, ages, usually in the early 60s. And Lewy body dementia is progressive. It's more rapidly progressive than Alzheimer's. Again, the end result looks very similar. And frontotemporal dementia, that occurs in the frontal lobes. And what's interesting is, again, it's very similar to Alzheimer's, the way it progresses, but the frontal lobe is responsible for making us behave. So our frontotemporal dementia patients, they're the ones who will take off all their clothes and go dance naked down the street. They may say a lot of sexual things. Men may be sexually aggressive. Even women may be sexually aggressive. So that becomes a problem in terms of controlling. And if they are in a nursing home or a rehab place, helping them to behave and to be in a situation where they're not offensive to other residents can be a problem. So behavioral issues are actually very difficult to contain sometimes. So protecting them and protecting other residents from them are sometimes more. But all of the dementias are memory loss, cognitive impairment, and impairment in activities of daily living. Okay, next slide. All right, but now let's just talk about, am I getting dementia? What's normal? What's not? How am I going to know? How do I know if my family member has it? How are we going to kind of incorporate this? So most people have trouble remembering events more than a year ago. Oh, I know we had that anniversary party, but I don't remember who was there. That's okay. But if you had a Zoom meeting last week, you really should know, I did go to a Zoom meeting last week, and you should know more or less who was there. You might not remember everybody, but you're going to remember that your particular group was there, or you did go to your book club last week. You should know that which book you read last week, but you might not remember which book you read a year ago. Most of us have trouble remembering acquaintances' names, but you should know the names of your family members. When you start to not know the name of family members, that's a big warning sign. We all forget things occasionally, but dementia patients are frequently forgetting things, and they forget things that are important. If you forget to come to see me at your office visit, you're in trouble, okay? Everybody knows that. But forgetting serious things really does matter. An occasional forget is okay, but when you are routinely forgetting things that you know are important, and think about things that are necessary. Did you pay the mortgage? Are you calling? If it's your daughter's birthday, you should know your daughter's birthday. You might occasionally forget an acquaintance's birthday, but you should never forget your daughter's birthday. Okay, you were there when she was born. Difficulty finding words. We occasionally find trouble looking for that. But frequent pauses and substitutions. When you say the word milk when you meant to say car, that kind of substitution is not normal. Now, if you are thinking about the word, oh, you know those flowers that follow the sun, like a sunflower, you know those flowers, and you're thinking of the word heliotrope, that's okay. You don't have to remember that word ever. But if you are putting the wrong word in incorrectly, that's a big problem. That's a word salad. That's a really a red flag. But the most important thing is that people who worry about their memory and they're saying, I couldn't remember, I met that guy and I couldn't remember, was that Mr. Jones or Mr. Smith? But you're really worried about it, probably not a problem. But when your family is worried about it, that's the red flag, because your family knows that you told the same story 6 times in the last 20 minutes. Your family knows that you forgot your daughter's birthday. Your family knows that you had just put your cell phone right in front of you, and now you don't remember that it was right there, and you said, don't let me forget, the cell phone is right here, and there it's right there, and you forgot it, like every single time. You can do that occasionally. You can't do it over and over and over. Okay, next slide. Financial decisions. We all make mistakes in the checkbook occasionally, but when you lose thousands of dollars or you send thousands of dollars incorrectly, that's a big problem. One of the things now is that the financial advisors are allowed to call and tell us that you're doing something really bad. So I had a patient and she met this lovely young man from Turkey on Facebook, and she wanted to send him $35,000. And fortunately, Lincoln Financial called me, and we were able to call Adult Protective Services, and they were able to stop that transfer. She didn't have $35,000 to give away. It was part of what she needed for her own retirement. That's the kind of financial advice that we need, and that's a financial decision that's not appropriate. Okay, you can make a mistake in your arithmetic. You can't send $35,000 to Turkey to some nice young man who really needs it. We can occasionally misplace, especially keys and things that, you can misplace them. But if you put the milk in the pantry and then try to drink it, that's a warning sign. The other thing is, you come to see me and they're paving. So you park your car. You always come to see me and you park your car over in this section, but they're paving, so you park your car over there. Now you come out and you go and look where your car, you always park your car in this section when you see Dr. Trifoglio, and it's not there. So you regroup. Wait a minute, where's my car? Oh, that's right, I had to park over here because they're paving. It's okay to take a minute and have to regroup. But if you come out and you don't see your car and you call the cops because you think your car is stolen because you cannot recall that you had to park over there instead of over here, that's a warning sign. And people do that. They call because their car is stolen, but they just parked it in a different spot, different from their usual pattern. Those are warning signs. Dressing for the weather. It's right now it's autumn, so the weather is very variable. I'll go in the morning and it'll be 45 degrees in the morning and 80 in the afternoon. So sometimes you wear the wrong thing. You go out, it's like, oh wow, it's much chillier than I thought, so you'll be a little cold. But if you wear 3 coats and it's 80 degrees, that's a warning sign. I had a lady and she was dancing in her underwear on East-West Highway, and it was February. That's not enough clothing for East-West Highway, and she shouldn't have been in her underwear to begin with. So that's the kind of thing that is just not appropriate for where she is. So using correct judgment. We talked about judgment and we talked about reasoning. If it's cold, I need more clothing. If it's hot, I need less clothing. And judgment, all of this, and reasoning. And driving. It's okay to miss a turn. It's okay to have an occasional fender bender. Getting lost on a familiar route, that's a big warning sign. So I had a lady and she was coming from Riverdale up to Greenbelt. And so that's like 2 exits and she got off. Well, she missed her exit. It's okay to miss your exit, especially with a little construction. Okay. But it was 2 exits. So what is that? 4 miles? She didn't get off the road until York, Pennsylvania. York, Pennsylvania. Okay. And then she said, I think I missed my exit. So she got lost on a familiar route, but she didn't have the ability or the judgment to say, I've gone too far. Okay. And when she got out of the car, she was so clearly upset that fortunately they called the cops and she was safe. But getting lost on a familiar route, going to church every Sunday, and then not being able to find the church or not being able to find your way home. Those are hallmark signs that you have dementia. It's okay to miss your turn occasionally. It's not okay to go to York, Pennsylvania en route to Greenbelt. And frequent accidents and misjudgments, starting to go up and down off the curb, not being able to judge where the car should be, taking out somebody on the sidewalk. I had a lady and she just went right through the glass of a storefront because she just couldn't judge where the edge was. It was the horizontal part, parking like this, right into the storefront. Those are signs that it's time to give up the car. And those are signs of dementia. So think about what you've been doing. And if you are on the normal side, relax. If you're starting to make mistakes on the dementia side, then it's time to see your doctor and talk about this some more. Okay, next slide. Can we prevent dementia? Now, the really good news is that vascular dementia can be prevented, and we are preventing it. And I just read a study that the reduction in vascular dementia is working, and that it's significantly lower. We have a much, much lower rate of vascular dementia right now. And it's simple things. Aspirin really is the miracle drug, 81 milligrams a day. It definitely helps. And the statins help, especially Lipitor, Zocor, and Crestor. That's atorvastatin, simvastatin, rosuvastatin. And this is actually somewhat good luck because they not only lower the cholesterol, they have an anti-inflammatory effect on the lining of the arteries in the brain. And that anti-inflammatory effect reduces the amount of plaque that develops, and it eats away at the plaque that has already developed in the arteries. So these are actually excellent. They reduce plaque, they do decrease inflammation, and so they therefore reduce your risk of stroke. And then since vascular dementia comes from little tiny strokes, it reduces it from happening. So if you have a little bit of early multi-infarct dementia that's just starting a little bit of vascular dementia and you take these medicines, it can stabilize it and get you to that plateau so that perhaps it won't occur anymore. Controlling blood pressure matters. Okay, so we talk about in the young people 120/80 and really keeping it down 120/80. As you get older, maybe not quite so tight a control, maybe like 140/80, but you don't want your blood pressure to be 180/80 or 190. You really want that blood pressure to be under control. It definitely helps because it reduces your risk of these tiny little strokes that lead to tiny little progressions in your loss of cognition. Now, atrial fibrillation is a big problem because it leads to these tiny little strokes. And we can treat AFib, and it's a combination of treating the rhythm problem, but AFib causes little blood clots to go to the brain. And we always used to use Coumadin, but now we're using Eliquis and Xarelto. Those are blood thinners. And that really has reduced our risk of vascular dementia. And there are other ways. We're doing more cardioversion, where the cardiologists are using different ways of either shocking the heart or doing other things. And then there are these other little procedures where they are taking out part of the little wing in the atria where the clots develop. So what they're doing is all these different modalities to reduce your risk of blood clots from atrial fibrillation. So by treating AFib, we are significantly reducing the strokes that come from it. And so the combination of an aspirin, statins, controlling blood pressure, and treating AFib, and also with anticoagulation in the presence of AFib, has significantly lowered vascular dementia, and we're seeing that over time. Okay, next slide. Now, Alzheimer's. Alzheimer's is harder to prevent, and we can't really truly prevent it, but we can slow its development and push off when it arrives. And so if we can do that, even if we postpone its development for a few years, that is significant improvement. Exercise matters. Let me say that again. Exercise matters. It turns out that that stimulates the brain, it gets oxygen to the brain, it dilates the arteries. It really does make a difference. As much as we talk about exercise for the heart, exercise helps the brain. Dancing and singing together stimulate the brain in ways that are just amazing. So singing and dancing help. Playing a musical instrument stimulates the brain in yet another way. And so singing, dancing, playing musical instruments, all of these things help the brain to function better and prevent Alzheimer's or postpone its development. Socializing, getting together, talking and laughing. Now, right now, we're not advocating that with coronavirus, but certainly getting together with the Zoom and talking and laughing and, you know, sending each other jokes and talking on the phone. If you can't do it in person, do it together, either FaceTime, Zoom, email. All of that does matter. And it turns out that learning something new helps, especially if it's different from what you've done your whole life. So I'm medical, right? So if I do something artistic or I do something musical, it fires up the opposite side of my brain. So when you do that, you're causing new synapses to form and it refires the whole rest of the brain. And it is preventive of decline in your nerve endings. So learning something new is one of the single most important things you can do to prevent dementia. Okay, next slide. Now, do we have pills to prevent Alzheimer's? Well, aspirin probably helps, and that's because of its anti-inflammatory effect. Again, 81 milligrams a day. They've been doing some studies on atorvastatin, again, because of its anti-inflammatory effect on the lining of the arteries. That seems to be helpful, although the problem with the studies are it takes 20 to 30 years to do a study to prevent Alzheimer's, and we're looking to target younger and younger. So the studies are ongoing, and they're looking into that. Aricept is a drug that we use to treat Alzheimer's and try to slow down its progression, but giving it at the onset of benign memory loss seems to help. This works to stabilize the cholinesterase bridge. And so we give this when people have benign memory loss, and it seems to reduce the number of patients who actually progress to Alzheimer's. And there's a Chinese herb that's being studied called huperzine, and that is something also that's being studied as a prevention for Alzheimer's. There are some other studies that are ongoing, but again, these studies are long and we don't have an answer. Now, there are some other things that have been done and other studies that are ongoing. We don't have enough results yet, and we're looking into it. Okay, next slide. Does it matter what we eat? We are looking into that as well. So this is the MIND diet. And what they are recommending is that you eat whole grains, at least one dark green salad and one other veggie, and berries at least twice a week. So this is back to the antioxidants that are natural, the dark green leafies and eating the berries and eating some nuts, but just an ounce. You don't want to eat too many calories, but an ounce of nuts every day. And beans or legumes every other day, eating poultry and fish. So this is getting away from the red meats. This is going towards poultry and fish. This is pretty similar to a Mediterranean diet. And so I think all of this goes along with other nutritional studies that you've seen. This adds a glass of red wine every day, but I don't know that I'm agreeing with this completely because wine can also promote dementia. So they say you could also substitute purple grape juice. They think that something in the red wine may be preventive of dementia, and that comes from some of the Italian studies. But I think that grape juice would work as well. And I'm not sure 5 ounces is the right amount as we age. I think you could do with 2 to 3 ounces because that alcohol as we get older can become toxic to the brain. So they're researching that. And avoiding the fats, limiting the cheese, avoiding fast food, and avoiding the pastries and sweets. So I think that generally speaking, this is a healthy diet to follow. They call it the MIND diet, and they're looking at this as a prevention. But certainly eating the dark green leafies, eating the veggies, eating the berries, all of these things I think are valuable. And they call this the MIND diet, designed to help protect and foster good mental acuity. All right, next slide. They're doing clinical trials. They're looking at different medications. They're looking at immune therapy. They're looking at monoclonal antibodies. Maybe you've heard about that. We're using monoclonal antibodies now for coronavirus. We use monoclonal antibodies already for cancer, and we use it for rheumatoid arthritis and for psoriatic arthritis. They're doing monoclonal antibody testing for Alzheimer's, and they're looking at vaccines. So right now, these things are ongoing, but again, we need a long lead time. The other thing for me that's fascinating is they're looking at patients in their 30s and 40s and trying to do the test. I think that's what's going to yield, because the testing that's been done when they take patients in their 50s and 60s, it's too late. The process has already started. Alzheimer's, there's a lot of problems in the nerve fibers, and the nerves are degenerating. They talk about neurofibrillatory tangles. They talk about tau proteins and beta amyloid. Once that process has started, they can't really reverse it. They talk about cleaning it out, plasmapheresis, but really that process, once it's started, reversing it or slowing it down, they've not had good success with. I think we need to keep it from starting. So I think when they start with patients in their 20s and 30s, that's where we're going to get a good benefit. And so that's where I think some of these newer treatments are coming. There's two references here, clinicaltrials.gov. Those are ongoing clinical trials. If you're interested in doing a trial, clinicaltrials.gov will tell you what's going on in our area. And alzheimers.org, that's just the ALZ.org, that will tell you clinical support, that will give you help in the community, that they have a ton of information available. I think Denise has information for you. There were some handouts that I think she can get you, or that you can get yourself at alzheimers.org. And they also have references to clinical trials that are ongoing. I think now we're going to turn it over and open it up to questions and answers. Next slide. I think we're done with slides, right?
Yeah, thank you very much. That was definitely very informative, even for a young person like me. Lots to think about. A few questions came in, and I want to reiterate again that if you have a question, feel free to type it into the chat box, or raise your hand, and then I call on you, and then you can unmute and ask the question directly that way. But a couple questions came in throughout that I'll ask, and then we can let people filter in more questions. That works.
Sure.
A question came in on about how staying at home was making distinguishing days from each other more difficult. It is easy to remember going to a lecture and talking about it to who you go with, but watching 4 or 5 lectures or more a week on Zoom makes each harder to remember, sort of both the lecture, when you did it, XYZ. Is this a problem, or just sort of a symptom of the pandemic?
That's actually a very valid point. There's 2 parts to this. It turns out that for patients with dementia, the coronavirus pandemic and the restrictions have accelerated the development of dementia, because they have had less social interactions, and because every day does blend into each other. For patients without dementia, we've lost our markers. Every day is a weekend, right? Every day has the same structure. So that's been a bit of a problem. It does mean that the memory cues are not there. So it's not indicative that you've got dementia, because you don't know what day of the week it is, because every day is the same. So I don't want you to think you have dementia because you can't remember every lecture that you went to, because they're not embedded in you in the same way. So I'm not suggesting right now that you use all these markers as significant as what I was implying before. You're right, the pandemic has shifted what we're doing. We are having trouble with the pandemic too, with patients' ability to concentrate, patients' ability to form new memory, and patients' ability to navigate just everyday life. So make an effort right now to learn something new, to broaden your horizons, to exercise, and to stay as socially connected as you can, because that does ward off dementia. It wards off depression, which can mimic dementia, and it can help you maintain just good, healthy brains. And as we age, if you lose some of your edge, you might not get it back. So we are asking everybody to try to work extra hard at maintaining. I hope that helps. Is that answering the question?
Thank you. I'll see if that answers the question. That was a very good question. A very relevant question right now. Another question sort of relevant now is, to what extent does stress impact memory and impact some of the markers that you mentioned earlier?
So we didn't talk about differential diagnosis for dementia. It turns out you have to be feeling well, be well rested, and not be depressed, and be in fairly good health in order to form memory. So some of my patients come in and they think they have dementia when in fact they are depressed, or they have not been sleeping well, or they've been taking Benadryl to sleep, which has bad effect on their memory even the next day. So if you're taking a medicine like Benadryl, for example, it has these metabolites that build up. And so it impairs you even the next day so that you can't form new memory. And then you don't form new memory, so you think, oh, I'm losing it, I've got dementia, when in fact you have pseudo dementia. It's fake dementia because you took too much Sominex or too much NyQuil. So sorting out what's really dementia and what's not is part of my job, and I can help you with that. So being able to form new memory means that you are able to concentrate on what you're doing. You're able to sort out noise from stress. And when you're stressed, you don't concentrate. So because we are all on edge right now, your ability to form new memory is probably somewhat impaired. The other thing is multitasking doesn't work. So that's another thing I always want my patients. Are you having trouble forming memory, or are you having trouble focusing? So, when we're younger, we do a little bit better. Like, I had two sons, and, the phone's ringing, and one of them is spilling his milk, and then the dog is there, and now I'm on the phone, and they're like, okay, so we're coming to clean your ducts next week. And I can remember that the duct cleaner's coming next week. But now, with all that going on, I might not remember the duct cleaner coming in 2 weeks. So all of a sudden the duct cleaner's here. Like, what are you doing here? Because I couldn't focus with the dog yowling and the kid spilling the milk and everything. I wouldn't be able to form that memory and put it in my brain. I'd have to write it down. So stress interferes with your ability to actually form. And as we get older, the ability to form memory is harder. So you have to focus. And if you have trouble forming memory, focus. Write it down. If it's super important, like I have to see Dr. Trifoglio on August 15th, write it down in red. In doing that, you're going to remember it better. And the pandemic has given everybody this consistent level of stress. The pandemic does it. There's a lot going on in the world that's stressful, and we're separated from people, and we're separated from our loved ones. All of this is making it harder to form new memory right now. So that gives us a sense of, oh, I'm going to be demented. That's not necessarily true in this era right now.
Okay, I've got a shorter question here. What about Advil instead of aspirin?
No, it's aspirin. It's not Advil, aspirin. And that has to do with the platelet inhibition and the anti-inflammatory effect of the aspirin. Advil doesn't do it.
Okay, well, that was a shorter question. Thank you. This question, I'm not sure I get, but you might understand. What is the value of the MOCA Montreal ...
Okay, so how do we assess dementia? Okay, so there are a lot of different tests that we can use. So the MOCA Montreal, it's a cognitive assessment. It's one of multiple tools we use in order to assess how is the patient doing. So your family sees you all the time. I see you for 20, 30 minutes. How am I going to judge? Are you demented? Are you just memory impaired or whatever? So we had the old mini mental status exam. I have a mini MOCA. I have the MOCA Montreal assessment. There's a 6-sit test. And all of these test different parts of the brain and how they work. And you have to count backwards from 10, give me the years, the months of the year backwards, draw a clock. And they test different parts of the brain. And they're pretty well designed to sort of span different sections of the brain and how they function. So we're testing memory, cognition, executive function, and the combination gives us an indication of how are you functioning and how impaired. None of them are 100%. All of them give us a little bit of a window. And if you use the same one over and over, you can see progression over time. So the Montreal Mocha is one of those. Some people use it, some don't. It's still copyrighted, so you have to pay to use it and you have to be trained to use it. So they use it in the big institutions. In the private offices, we don't necessarily use it. We use like the mini cog and some of the others instead.
Okay, there's two more along those lines that are similar. One is just sort of recommendations for evaluation from an older adult who has issues with memory recall and would like to start sort of statins, but not on them currently. And then another question on how do you diagnose Alzheimer's given the presence of all sorts of other things that could potentially be causing said issues. So there's two sort of related questions on evaluation.
So one would hope you have a good internist or geriatrician. And we start with the basics. Like the first thing you do is you go in for a basic evaluation because there are other things that could be impacting you. So we check a physical exam and we do a basic, how are you? What medicines are you on? What medicines are you taking that could be affecting you personally? Like there are prescription drugs and over-the-counter drugs that can fog your head. So you want to eliminate those. So looking at polypharmacy, what other medicines can be affecting you? And then some basic blood work. Make sure your calcium level is normal, your thyroid level is normal, your B12 level is normal. And just doing a general medical assessment to make sure that some of the things of aging are not actually causing some of these symptoms. What is your cholesterol level? What are your risk factors? And then what would you like to do? What are your wishes and what are your goals? And then maybe doing a mental status exam. And then do you need a basic CAT scan? Just looking at for some of these secondary causes. So making sure there is no brain tumor, that there is no pressure in the brain. Are you falling? So we start with a basic assessment. Alzheimer's is a clinical diagnosis done by the clinician. That would be me, the doctor. And then we move forward from there. If you don't have a good primary doctor, then you would think about maybe seeing a neurologist to see if they are, but you would want one who is good at diagnosing and working with you and not just doing a boatload of tests and sending you on your way.
Great, thank you. There's a few more good questions I do want to get to, even though we're running up out of time, but I do want to make sure we get to these. There's three more good questions here. One was sort of a more specific question on Crestor, because it lists memory loss as a side effect. Is that a too specific question for this moment?
No, it's not. Rosuvastatin and Crestor list that as a side effect, but that's been debunked. That's not true. There have been many follow-up studies. It does not cause memory loss. None of the statins cause it. That data has come out within the last year, and it's not true. That has been debunked.
Great. The question on, does a daily meditation class, yoga, that sort of category have any effect on the rate of decline?
I think personally those help, but I don't have data that confirms that. But I think meditation is mindfulness. I think it helps you settle the brain. I think it's mind control in terms of getting stress under control, concentration, focus. I think that can only help. I think yoga is helpful because it's a form of exercise and it's a form of muscle control. So I think that those things are helpful, and it would fall, I mean, all of the research about exercise, learning something new, working with like music and dancing, and all of those things have been shown to be helpful. I think meditation, yoga, all of that would fall into those categories. So I think it would overlap, even though I can't call to mind a study that confirms it. I think it would be in that category. Next
okay.
Question?
There's more questions coming in. Someone about, do you recommend aspirin for everyone? Someone said they used to take it, but they don't take it anymore. Is that worth going to talk to the doctor again?
Yeah, so I'm not telling anybody what to do, but we used to recommend aspirin 81 milligrams for everybody age 50 and above for prevention of heart attack. Now what they're saying is that has to be fine-tuned for people who have heart disease, high cholesterol, or a high risk. That I'm talking about aspirin as a prevention for dementia. So that's a different category. It's a different subgroup of people, but also older people have other risk factors. I mean, we worry about ulcers and bleeding and other problems. So you would want to talk to your physician about it, but aspirin has been shown to reduce the risk of vascular dementia in the presence of high blood pressure, hardening of the arteries, and diabetes. I also want to say a new study just came out like 2 weeks ago that showed that metformin reduces dementia in diabetic patients. That's very powerful information, and we're happy to see that. This is new information and one study, so it needs to be proven. Okay, all studies need to be redone and double checked, but it does seem to be really a good marker that would be a helpful thing, because metformin is a good drug for diabetes, but if it prevents dementia in that population, that's helpful. So individually, you want to talk to your doctor about those sorts of things.
Okay, there's a question here. Do you think it's necessary to see a neurologist for any sort of diagnosis, or are these just your regular physician?
I don't know who your regular physician is. If you have a good internist geriatrician, that's usually enough. If you're not competent or comfortable, then a neurologist is reasonable. And if you're very worried, Hopkins has a great section. They have a whole cognitive assessment clinic, and probably GW does also.
Okay, thank you. And then there's one more, one last question here. Then again, if you have any last questions come in, if not, we'll wrap up after this one. But it was a specific question on Trifoglio, I think I'm saying that right, for cholesterol. Is that one of the ones you listed earlier? I don't remember if I'm saying that correctly at all.
Pravachol, they use for cholesterol. It's not as anti-inflammatory as the others. If Pravachol is the one that agrees with you, I wouldn't change it, but it's not as anti-inflammatory as the others.
Along those lines, we had a question: is inflammation an issue for?
Yes, we believe that inflammation has something to do with how everything is progressing. Inflammation definitely has something to do with the atherosclerotic development of multi-infarct dementia. It's atherosclerosis develops because of inflammation in the lining of the little arteries in the brain. Now, does that have to do with the development of Alzheimer's? We're still figuring that out. There's a lot of stuff that goes on in Alzheimer's that we know is there, but we don't know exactly what triggers it and how it progresses. So we do think inflammation has a lot to do with it, but how to figure that out, how to fix it, how to stop it, we don't know yet. We just don't know. We're trying, but we don't know.
Great. Well, that was the last of the questions, but I want to say thank you very much. And I'm sure Denise does as well, but I definitely found that very informative.
Okay,
thank you.
Good. All right. Thank you very much for having me.
Thank you very much, Dr. T, for taking the time to meet with all of us this morning. I just want to sort of re-quote something that you said in a previous presentation I observed you on discussing dementia, and that was that that if the patient is coming to you and saying, I'm worried about having dementia, that's probably not an issue for that person, that it's much more likely to be a family member coming to you and saying, you know, I'm worried about my fill in the blank. You know, it's the kind of thing that sort of sneaks up on you. And I think that's something that I've held on to.
Right. Yes. It's usually the family members who see it and not the patient. The loss of insight is a problem in dementia. They don't have that insight. Correct.
Well, thank you so much for joining us, and thanks to all of you for participating in the meeting this afternoon. I hope you learned something, and we'll look forward to having you attend other programs. Take care.